So this isn't necessarily an interesting case, but it was kind of more of an interesting discussion. It ties into Rana's talk about evaluation of secondary mitral regurgitation and evaluation for TEER, and specifically how it relates to heart failure therapy. So there are challenges with essentially measuring secondary mitral regurgitation and how it's treated. So we're just going to review a case. We're going to review the pathophysiology, challenges in measuring it, and kind of evolving definitions of how we characterize severity for secondary MR. So the case was someone that came to the echo lab last week. So it was a 62-year-old with a non-ischemic cardiomyopathy. He's had long-standing HFrEF with an EF of around 30%. This was thought to be secondary to long-standing use of both alcohol and permanent atrial fibrillation, which tend to be interrelated. He recently had an ICD and CRT implanted in January. Despite the implantation of the CRT device, he's had persistent kind of symptoms on goal-directed therapy, which is outlined there, and persistent volume overload. His ECG shows permanent atrial fibrillation. He's paced occasionally, but the press was still quite wide while paced. And so we look at his peristernal long axis images. You can see that he has a very dilated left ventricle. His right ventricle actually looks okay and relatively normal function. He has a very dilated left as well. And we can see the end systolic and diastolic diameters. So his end diastolic diameter is over 7. And this is our first picture of mitral regurgitation. Looking like it's posterior, it's kind of central posteriorly directed. And then we have a nice zoomed view here where we see flow convergence. We've dropped the ALizing velocity to demonstrate this. And then we move to our apical 4-chamber where we have a really nice view of the leaflets. And so we love to see this view zoomed in. You can see the leaflets very clearly. You can see some apical tenting of both leaflets. The posterior leaflet looks more affected. And we can see some relative override of the anterior leaflet, likely explaining more of a mixed picture, which we'll touch on in a second, and also explaining why the jet is posteriorly directed. And then this is also great to get a color compare, so we can actually see where the flow convergence started. And again, a nice zoomed view for a sonographer, so I'm not straining at the computer trying to look at where the leaflets are. These zoomed color compare views are great to not only confirm kind of the pathology and the anatomy, but also see where the jet of MR is coming from. And similarly, when we drop the baseline and look for the flow convergence, zoomed view is also very helpful because off of these views, we're going to be measuring our PISA. And so having a zoomed view allows us to kind of be a little bit more definitive with our measurements because those measurements are going to be squared. And so even a couple millimeters makes a big difference. So when it's not zoomed, it's actually quite difficult to see where the flow convergence ends. So these types of pictures are perfect. And as Phoebe mentioned, we love our sweeps as well because we get to see kind of the MR across a couple of different scallops and we can see here that it's more of an eccentric jet that's posteriorly directed. Moving on to our 3-chamber view. Again, we can see nice leaflet identification here. You can see the MR. You can also see that it's a little bit dynamic, looks worse in some beasts as opposed to others, which becomes relevant. This is another sweep here. This is our velocities and VTIs. Our E-wave velocity, just over 1.2, and our pulmonary veins, which as frequently with these eccentric jets are kind of indeterminate. And so overall, you had a very dilated LV, and when we quantified it out, it was kind of in the moderate range. The ERA was 0.3, regurgitation volume was 39. And so part of the challenge is integrating all of this information to the clinical picture and deciding on both severity, but also clinical management. And so when we talk about secondary MR, these are two distinct pathologies from primary MR. And so for secondary MR, you have normal leaflets, and because of geometry changes within the heart, you get essentially movement or tethering of the leaflets that create a coaptation gap. And so there's both ventricular, atrial, and both. And so we know more so as we're learning about this patient population that there's a significant overlap between the two. And even in the case that we just saw, with both atrial dilation and ventricular dilation, you can get different patterns of tethering of the leaflets and contributions. And so I've found throughout my training that really looking at the leaflets and interrogating the leaflets in multiple different views and kind of building a story when you start with your parexternal lung becomes very important with kind of trying to identify the pathology. And so you can kind of have your classical apical tenting of the leaflets with ventricular remodeling. You can get more of a flattening, but still dilation of those leaflets secondary to atrial remodeling. And then you can have various kind of tethering of the leaflets, whether that be atrial remodeling or a wall motion abnormality tethering the posterior leaflet. And so I find that really paying attention to the leaflet's morphology, in addition to the other dimensions that you're looking at, can kind of help you interpret the pathology. And so those pictures where we zoom in on the leaflets become very important. I won't dwell too much on this, but I just want to focus that defining MR is obviously multi-parametric. So we look at all of these different things. And specifically for secondary MR, there is controversy regarding kind of PISA-derived measurements and how the cutoffs for EOA have changed over the last couple of years. But the focus on this is that we really look at all different types of measurements. So we're integrating the visual color, vena contracta, pulmonary vein interrogation, the inflow pattern, the EA pattern if there is an A wave, as well as the LV size and function, LA size, and then downstream effects with pulmonary hypertension and tricuspid regurgitation to try to come up with a gradient severity, because the quantification is really fraught with error, and this error becomes magnified with secondary MR. And so the reason that the PISA is difficult in secondary MR is that the orifice shape is actually different. And so with primary MR, we tend to estimate that the orifice is more circular. And so our PISA framework and calculations are really based off this circular orifice. Whereas with stretching of the leaflets and tenting of the leaflets, we more so get this elliptical. And so the PISA, as we can see on the bottom shape here, may not change very much because this is kind of the radius or diameter we're measuring, but it's the longitudinal elliptical shape of the orifice that changes. And so you can really underestimate how big the coaptation gap is just based on measuring the longitudinal dimension here. And this becomes an issue with measuring MR. There is volumetric approaches, but I'm just going to skip this for the time being just because of the sake of timing. The other issue that comes up with secondary MR is that it's very, very dynamic. So not only where you measure the PISA, but also the effective loading conditions. That's both blood pressure, preload, how optimized they are medically, if they're sedated intraoperatively or getting a TE. These things all impact the degree of secondary MR. And then also the rhythm of the patient. Are they paced? Are they CRT paced? Are they RV paced? Are they in atrial fibrillation, which can impact filling? And also if there's relative AV block. And so most of these patients will have these associated pathologies, so it makes it difficult to kind of measure. And so I started off very keen in my echo fellowship there in the top form in July 1st, thinking it was fun to measure MR. And now I see myself as the bottom one with the bonus of chains, which we don't have obviously in the St. Mike's Echo Lab. But this is what quantification has led me to. And so the difficulties with grading MR is that we have not only reduced geometry and also different dynamics, also that a lot of the other surrogate findings can be confounded in heart failure. And the total stroke volume that we're measuring is actually more reduced, and so that can cause error in measurements. And so because of this, the kind of cutoffs for both regurgitant volume and EROA that we measure with quantification in secondary MR has actually changed over time. And so in the past, we had the same cutoffs essentially for primary and secondary MR when we were doing our quantifications. And that changed in 2014 when the guidelines actually recommended a lower EROA and a lower regurgitant volume for all of the issues that I just mentioned. And they thought that, this would be able to actually capture more amount of people that are actually more in the moderate to severe range because of the errors in measurement. But there was a lot of criticism after this because the EROA changes in these patients. It's difficult to measure, but it's also dynamic and it also changes. And we may overcall MR in a lot of these patients. And so this is where the idea of proportionality comes out. So you may hear proportionate MR or disproportionate MR. And this is where these principles came out to try to understand this patient population more. And the other thing is that back here, the EROA cutoff was made lower because we knew that these patients did worse. But the problem was that with surgical correction, it didn't impact the patient outcomes as much. And so we didn't really know what to do with this patient population, even if we identified them as more high risk. And then, of course, that's changed over the last decade with percutaneous procedures showing that in the co-opt and both reshape trials that lower EROAs still benefited. And probably the most telling thing that came out of these trials is that lower ERAs both benefited, but their volumes were much lower compared to the MITRA, which was a negative trial. So the concept of proportionality kind of came into the forefront where, yes, we should be measuring EROA in the same fashion, but we really have to put it in context of the volumes of the patients. And so smaller LVs with more MR tend to benefit more, and that was highlighted in the co-op trial. Less so in the reshape trial. There was no change in mortality, but decrease in symptoms and hospitalizations, which are still obviously important. But the MITRA trial was thought to be negative because in relation to how dilated the left ventricle was, their MR was less proportionate. And so over the last couple of years now, there's been talk in the literature of essentially still quantifying MR similarly, but having an additional parameter to highlight proportionality. And so a ratio has been cited in the literature that have shown to be more favorable in terms of outcomes for transcatheter evaluation. And so the ratio of 0.15, so the more MR with the less dilation, and then in terms of volumes, more favorable gray and unfavorable zone. To my knowledge, looking through the sub-indexes, these volumes are mainly non-contrast pictures, and so hard to know with contrast because those volumes will obviously be larger and more reflect MRI volumes. And so I thought it was just an interesting discussion because at some of the conferences I've been to in the last year or so, they've talked about how grading MR is secondary MR in particular is very challenging, and that the EROA doesn't really tell the whole story, and how putting it in the context of the patient, but also the proportionality of the LV dilation is becoming more important to see which patients will benefit from transcatheter intervention. And so that's why you'll see that more trials are actually enrolling people that traditionally fit into the moderate or moderate to severe MR because of the quantification issues. But that's more so based on, again, the degree of MR in context of their LV dimensions. And so in the future, we may have to change our language in how we report these in the TEs, in transthoracic or transesophageal echoes, and saying, is this more hemodynamically significant or is this more proportional functional MR as opposed to the parameters that we're giving right now? And if we go back to our case just to apply this framework, his EROA was kind of in the moderate range, and his LV dimensions were huge. And so if we look at this proportionality framework, he was well below kind of our threshold. And so he more has like expected MR with this degree of LV dilation. And so this is kind of someone who more so falls in the MITRA trials and may not benefit from TEER as much. And may need just more focus on GDMT, advanced heart failure workup, device optimization. That's it.
So thank you, and to all our three fellows and who presented this round. It brings me back all the way to when I started actually at St. Mike's, where we had this room. Before it was remodeled, all our chairs on this side, and then the TV was on that side. Every morning we have to roll in, on Thursday morning, we have to roll in the big TV with the tape. I think some of you remember, right? Beam, were you there? And, yeah, with Dr. Robinson and everyone else. And I think Dr. Jeremy would just join us. I think we're still on TV at that point, right?
Not on TV, no, not that. Wait,
the tape? You're still very young. Very good. Congratulations. Anyway, we started off that, and the night before we had to actually wind our tape, make sure that we are in the right spot, and etc. So this is actually great set of rounds. So thank you for presenting that, and it's a great way to share our knowledge as well. And Mike, should we include proportionate MR or the ratio in our reporting routinely?
Yeah, I think it's funny that some of the conferences that I've attended, a lot of this literature has been obviously driven by industry and trying to study different populations. I think, as an echocardiographer, I would say that a lot of these decisions are not just based on the echo itself and the measurements that we make, because those are notoriously fraught with error. It's really about the patient in front of you, what medications they're on, how optimized they are, how symptomatic they are. And so I think that potentially highlighting it in an echo report can be difficult depending on who that report's going to. And so I think that having a good relationship with your structural heart team and more of a multi-D approach is probably best, as opposed to putting it into a report that may not be going to someone who is able to interpret this, and it could be damaging in that way. So I think that's more so relevant for a multi-D discussion as opposed to putting this in reports, but it's interesting how this may change in the future as more transcatheter options are being offered, essentially.